part of the problem has been that there was a desire by many women, and I totally appreciate it, to try to reduce risk the natural way. And we had had so many good examples by activity, not smoking, diet, all the things that are more natural and are good, that there was a belief that we could really dramatically reduce breast cancer risk that way. But I think that in some sense we've looked very, very hard for those, and we haven't found that the way to do it, the so-called natural way. And for reasons I was describing, I think the natural way is not the way to go. So it's in somewhat, I think many people do view it perhaps as a little compromise, that we using a pharmacological hormonal preparation to compensate. And I can, again, understand the reluctance, but I think in some ways that's where the research data have taken us. And it does sound like there's a lot of work ahead for us to better focus in on who could benefit. And one of the ways to do that is to be able to identify risk of women before breast cancer much better than we have been able to do. Up until now, there's been something called the Gale model, which you put in a few variables, your age and whether you had benign breast disease and a number of children. And that doesn't actually predict risk very well, but we're working now on putting together some other variables that I'm confident are going to be much more effective at predicting an individual's risk. Actually, the amount of breast density on the mammogram, we take mammograms to pick up breast cancer, but also we can measure the amount of dense tissue that shows up on the mammogram, and that is the most powerful predictor of breast cancer risk that we've been able to find out so far outside of BRCA1 or some very rare genes. And we haven't used that clinically at all. So incorporating that into our risk prediction, I think is going to put us way beyond what's been available until recently. And also, our group, working with some others, have just finished some whole genome scans where we look at a million different genetic variants in every person's gene, and have out of that process, going through many thousands of women who had their DNA of women who had breast cancer and those who did not. There are a handful of genes that are sort of small risk predictors, but it looks like when you add them up, they will enhance risk prediction as well. And then we've also done some studies using blood levels of hormones predicting risk, and found that prolactin as well as some estrogen fractions add to risk prediction. So what we're trying to do now is put all of these together, and when you combine them, I think we'll be able to do a much better job at identifying who's at higher risk and therefore more likely to benefit from Avista or some, perhaps, hopefully some even better anti-estrogen drug with more benefit, fewer side effects. But I'm pretty optimistic that this is potentially a way to really have some major impacts on reducing the risk of breast cancer for many people. The challenge is to optimize the use of it so that the people who can benefit the most and have the fewest side effects.